Hello, welcome everyone. Thanks for joining our echo session today. We'll give it just another minute to let a few other people join before we get rolling. In the meantime, if you want to add your name and email in the chat, that will help if you need to connect with anybody later. Any networking, that would be wonderful. And I see Janelle just dropped in the chat the survey for this June session. We'd love it if you could fill that out. Anybody who attends today, that's also something you'll need to fill out if you would like a certificate of attendance or Utah social work education, continuing education units. So fill that out. We'll also send that in an email reminder as well. So it won't just be here in the chat. All right, I'm going to go ahead and get going through some of our housekeeping here. We'll hopefully have a few other people join so we can get rolling with the presentation in a minute. Thanks again for coming. I'm Rachel Byers. I'm a project coordinator here at the Institute for Disability Research Policy and Practice. And this ECHO is part of our mental health and intellectual and developmental disabilities training initiative that's going on here in Utah right now. We will be recording this for educational and quality improvement purposes. If you're participating, you are consenting to be recorded. If at any point you'd like to leave because you don't want to be recorded, that's totally fine. You are able to leave. A few quick Zoom tips. A lot of us have been doing this now for multiple years, but if you'd like to rename your profile and can't remember how, you can look at this here. You'll go to the three dots by your name. If you are looking at your video square, click on those and there should be an option to rename. It's helpful also if you put your place of employment or your occupation in your name so people know where you're coming from when you give input and perspectives. You can also raise your hand if you'd like to at any point if you have a question or a comment. And if at any point you need to do one of these two and can't remember, drop that in the chat and we will put some instructions in there. Given that this is an echo and we'll be sharing stories, giving input, and we'll have a case presentation later, it's important to remember that we need to try and protect individual privacy. So when you're sharing information about another person, if you're giving an example, if we're talking about a case study, avoid using their real first, middle, or last name or initials. Use a pseudonym, a fake name that will protect their identity. Don't identify their family members, friends, or coworkers either. Those should be used pseudonyms. Similarly, don't provide any contact information, so email address, phone number. I don't know why anybody would, but that's something we want to avoid as well. And just in general, remember to de-identify examples and situations you're discussing. And if you're unsure about something, if you should de-identify a situation or if something counts as personal information, feel free to message me or a member of our hub team and we can answer that for you. Echo sessions are definitely intended to be very interactive. They're long, they're 90 minutes, but when you participate, they generally don't feel that long. We have a short or shorter didactic presentation that'll be about 45 minutes. And then we'll follow that up with a case discussion and a very interactive group discussion where we work through that case together. So it's very much intended to be an interactive community where we have our presenter, stakeholders across groups, and community members where we all communicate and support each other during this session. We are encouraged to be engaged in asking questions after the presentation and providing feedback for the case. Case narratives are definitely the best way to solidify skills and apply what we learn to real-world situations. If you have a case or a scenario in your work that you would like to talk about or work through together in one of these sessions, we'd be happy to do that. We'll have an email address here later in the slides that you can send that to. And we'd love to have you present a case and provide some support in working through that. So as I mentioned, we'll have a didactic presentation. Today it's Beth Grosso. We're happy to have her here. This is considered a community of practice where we're sharing knowledge and working through something together. After that didactic presentation, we'll have a case presentation today by Matt Wappett, who is our executive director here, and you'll have an opportunity to provide some feedback and work through that together. A nod to that case study opportunity again. This is an opportunity to work through any real life challenges that you're facing, real life scenarios. You'll get to hear from peers and colleagues in similar situations, receive some valuable feedback that you can take back and apply to your case. If you do want to, you can email this email, which I'll drop in the chat. It's MHIDD@aggies.usu.edu. Again, if you'd like a certificate of attendance, or we also have Utah Social Work Board CEUs, you'll need to fill out the survey that is in the chat and will also be in the follow-up email that we send out. You'll be able to let us know if you would like a certificate of attendance or those continuing education units, and we'll make sure we get those to you if you request them. We do also have a Canvas page where we place recorded sessions. The didactic presentation is recorded and is uploaded to there after each session. When we go through the case presentation, we will also take notes and put those recommendations together. That will be on the Canvas page as well. And any other resources that are applicable, we will put there. So if you'd like to have access to those, you'll need to register for the Canvas page. Similar to the case presentation, if you'd like to register for that, you'll need to email us at mhidd@aggies.usu.edu to get those instructions, and we can help you register if needed. Today, we have, as I mentioned, Beth Grosso here with us. She's a macro social worker with over a decade of expertise in the field of intellectual and developmental disabilities, or IDD, and mental health. She has experience in leadership, curriculum design, training and professional development, care coordination, outpatient therapy, and clinical supervision. Currently as the Director of Training and Professional Development at the National Center for START Services, she oversees a robust training and professional development department that offers both START-focused training and certification, as well as IDD, MH training and professional development for the community at large. She has served as the co-chair of the annual START National Training Institute since the inaugural training in 2016. Beth is passionate about issues related to cultural competency, diversity, equity, inclusion, justice, access, and belonging. She has previously served as the stakeholder engagement coordinator in START research projects and continues her commitment to elevating the voices and perspectives of people with lived experience of IDD and MH. When not at work, you can find Beth spending time with her two awesome kids, reading and enjoying live music. We'll have Beth present here in just a moment. Quick nod to our social media, and I'll pull this up at the end if you'd like to as well. We are on Instagram as well as Facebook. If you scan this QR code, it will take you there. If you follow, you'll get updates on other echoes that are happening and upcoming sessions. Our next session is July 10th. It will be behavior as communication within the context of mental health concerns. If you haven't registered for that, please do so. And Beth, I'll turn it over to you.
Thank you, Rachel. I should have known better when I sent you my bio that I'd have to listen to it being read back to me. Yeah. That was a short-sighted move on my part. Hi, everybody. I'm really excited to be here today to talk to you about the topic today, which is the importance of mental health literacy for direct support professionals who provide care and support to people with intellectual and developmental disabilities. My bio had the term IDD-MH, and just a disclaimer that you're going to see that term quite a bit in this presentation, and that stands for intellectual and developmental disabilities and mental health needs. So you already heard an earful about me. My top 3 character strengths, we use the VIA character strengths here at the National Center and with our START teams. My top 3 character strengths that I lead with in the work that I do are creativity, love of learning, and hope. And I hope all 3 of those come through in my presentation today. I am a social worker by profession and in my heart, and I've been working with the START model for over a decade and people with IDD for over 15 years. Over the last 10 years, I've worn a lot of hats in and around the START model. One of the things that originally drew me to START was the model's recognition that people with IDD do indeed have mental health needs. And up until that point in my career, it seemed like I was experiencing systems of care that actively denied this reality and sort of built their structures around circumventing mental health care, to be quite frank. And second to that was START's true application of a strength-based practice in a really radical way when faced with deficit-focused systems. And both of these elements contribute to increasing mental health literacy. For those of you who may not be familiar with START, START is an acronym that stands for Systemic, Therapeutic, Assessment, Resources, and Treatment. And it's an evidence-based model that works with the system of care to build capacity and a really strong safety net for people with IDD who frequently experience crisis. So it's not surprising that START resonated with me because it reflects a lot of social work's core values, including seeing the person referred to START within the context of a system of support that needs intervention as much, if not more, than the person themselves. The National Center for START Services, which is where I work, oversees the implementation of the START model in over 33 regional or statewide programs across 11 states. We also conduct research and evaluation on topics related to IDD-MH, and of course, we provide a rich array of training to START teams across the country to build their mental health literacy within the context of the START model. And NCSS has also developed trainings for the community at large, and one such training is a 6-week DSP course that is co-facilitated by a person with lived experience. And several Utahns, I'm not sure if I said that correctly, but I'm trying to be culturally competent, have taken this course, and we'll get a little bit more in detail about that later on. So this is a fun slide that just highlights the partnership between NCSS and USU's Institute for Disability Research and Policy and Practice, which is how Utahns have accessed the course. If anyone wants to correct my pronunciation, I welcome you to do that.
Utahns is great.
Utahns, got it. Okay, learning objectives. So what are we going to achieve during our short time together? The first thing that we're going to do is we're going to define at least 3 principles of mental health literacy. Secondly, we're going to describe why building the mental health literacy of direct support professionals matters. And finally, we're going to be able to identify at least 2 resources that can be used to promote mental health literacy for DSPs. I am all about trainings having something for people to take away with them and continue their learning. So now that we've set forth the objectives, I'd like to check in with you all. And I've collaborated with Rachel to set up a Zoom poll to rate your current level of familiarity. I always like to know my audience, and this is my opportunity to do that. So if you wouldn't mind sharing your current level of familiarity with the concept of mental health literacy, we can launch that Zoom poll now and get an idea about where we all are. I can't see the screen at all, so if there's anything going on that I need to know about. Someone could just read the results when they're done. That'd be great.
Yes, absolutely. I'll see if it'll share it after too, but we've just about all answered it.
Okay.
So far, so we have very familiar 1 out of 24, familiar 11 out of 24, somewhat familiar 9 out of 24, and not at all familiar 3 out of 24.
Okay. Well, thank you so much. And that is, oh, there I see the results. So most of us today fall somewhere within the familiar to somewhat familiar, which is absolutely perfect, right? My hope is that this presentation will provide something new to those who are familiar, and perhaps a little bit more to those who were somewhat familiar or not at all. So thanks again for participating in the poll. All right, a little background on mental health literacy came about in around 1997 and has seen several evolutions since its inception. And the most recent evolution has evolved to a model that's often referred to as positive mental health literacy. And the tenets, the 4 tenets that you see on your screen right now, correspond to that positive mental health literacy. So the first is understanding how to obtain and maintain positive mental health. Second is understanding mental disorders and their treatments. Third is decreasing stigma related to mental disorders. We know that stigma is a really significant barrier, both in identifying and seeking treatment. And that leads us to our last, which is enhancing help-seeking efficacy. So knowing when and where to seek help and developing competencies designed to improve one's mental health care and self-management capabilities. So what this definition offers is a focus on the promotion of mental health and mental wellness, whereas previous iterations focused solely on identifying and treating a mental health crisis. Right? So when talking about concepts, I like to place them within a broader context. I think it helps us attach this concept of mental health literacy to concepts that we might already be familiar with to deepen our learning. So mental health literacy, as you can see on the screen, is derived from the broader concept of health literacy, which is premised on the idea that low literacy leads to poor health outcomes, which means that if you improve literacy, we can improve outcomes. And we know that mental health literacy is low across the board because of poor outcomes people with IDD and mental health needs frequently experience. Things like frequent visits to emergency departments, frequent hospitalizations, arrests and incarceration, frequent moves or changes in programming, lack of access to appropriate mental health care. So by improving literacy, we can improve outcomes for people with IDD and mental health needs, their families, and their communities. And so this tiny bubble here, IDDMH literacy, points to the need to tailor the design based on particular populations. So those populations might be children, teens, or in this instance, children or adults with IDD. And we're going to talk a little bit more about why. So these prevalence rates of 40% of people with IDD and 21% of people without IDD certainly justify why a tailored approach is needed. And so we've laid out a working definition, and we understand why mental health literacy matters. We're going to focus on our 2 primary groups today. First, people with IDD and mental health needs, and then we're going to talk about the direct support professionals that support them. So starting with people with IDD, what we know is that 40% of people with IDD experience a mental health need in their lifetime, compared to 21% of the non-IDD population. And despite this drastic difference in prevalence, people with IDD are underdiagnosed, they're not treated, or they're misdiagnosed far more than the non-IDD population. So income direct support professionals, the backbone, and if we're being honest, the guts of the developmental services delivery system. They support people with IDD 24/7, 365 in a variety of roles and settings. This list of bullets that you see on your screen is a very short summary. They're responsible for providing personal care, daily living support, and skill building. They are a primary source of emotional support, access to recreational activities, and transportation. In the role of a DSP, they have to be able to multitask, be organized in their thinking and planning. They have to apply a high level of creativity, and they need to be able to make quick, informed decisions. There is very minimal field supervision that's provided to DSPs. So they're critical, and their role is critical in the promotion of quality of life for people with IDD and mental health needs. And since we just covered that more than 40% of people with IDD are diagnosed with co-occurring mental health needs, this population of DSPs and training them and building their mental health literacy is critical. Yet evidence continually suggests that DSPs don't consistently receive training on best practices for positive inclusive supports, and they're not getting training on mental health literacy, on those principles that we covered a few slides back. And just one short side note that our time together doesn't allow, but that must be said out loud, DSPs as a workforce are facing a crisis. Low wages, lack of benefits, and limited opportunities for advancement are just naming some at the top of a long list of issues facing DSPs. So it's more important now than ever that we provide DSPs with the skills and tools that they need to be effective in delivering care. And we're going to talk a little bit more about what that might look like. So we've defined what mental health literacy means, and we've talked about why it matters and why it's so important, especially for direct support professionals who are providing this direct support to people with IDD. Now let's look at current efforts that are aimed at building mental health literacy. So the first thing that I want you to know is that we have a nicely designed curriculum that was developed right here at USU. A friend of NCSS and a valued research partner, Ty Aller and colleagues, developed the mental health awareness and advocacy curriculum. And the three areas of emphasis for this directly correspond, and I think nicely distill the principles of mental health literacy into these three pillars that you see here on your screen. First, identify signs and symptoms of mental health concerns. Second, locate evidence-based mental health resources. And third, effectively and appropriately respond to mental health concerns. The first, the ability to identify signs and symptoms of mental health concerns, was demonstrated when a person stopped doing arts and crafts activities that they enjoyed and declined social invitations. The DSP then engaged in a process to locate evidence-based mental health resources and ensure the person's immediate mental health needs were met. Aller and colleagues' article uses a vignette, and that was just a sample to demonstrate how each aspect of the curriculum can be utilized. It's a wonderful article, and the reference is listed at the bottom of my presentation, and I highly encourage you to read it. It's really groundbreaking in sort of putting literacy, mental health literacy, into action. So another example of building mental health literacy comes from where I work at the National Center for START Services. We have a course for direct support professionals, the mental health aspects of IDD. And this is a 6-week course that's held live via Zoom for 105 minutes each week. The session is designed to provide direct instruction and opportunities for chatting and discussion and reflection and questions, really focused on applying what's being learned. As I mentioned earlier in my introduction, this course is co-facilitated by a person with the lived experience of IDDMH, and I can't emphasize how valuable that has been, both to the delivery of the course content, but most importantly to our participants. And we've seen that time and time again with feedback, that having a person with lived experiences, insights, and ability to respond to questions in the moment within that course has been really transformative to the learning experience. So those who attend all 6 sessions can earn a certificate of completion and 10.5 CEUs. And that is really also attempting to professionalize the field of direct support, right? And helping them to build their skill set and their competence and confidence. This course is offered 2 times a year. We offer it in the fall and then in the spring. So I realize that this slide is very text dense, but I wanted you to be able to see the topics that are outlined within each section. As you can see, the first 4 sessions are titled Foundations, and they're really focused on building foundations of understanding regarding the intersection of mental health and IDD. Whereas the final 2 dive really headfirst into a plethora of therapeutic interventions. And this really kind of goes back to Ty's research study that talks about sort of being able to name and identify what the mental health needs are of people with IDD, what it might look like if a mental health need shows up, and then equipping them with the tools and resources they need to provide positive person-centered support, but also identify additional resources that are needed for that person outside the realm of their support that they're providing. There's also one aspect of this course that I wanted to highlight, and that's the use of positive psychology. So our belief here at the National Center is that using positive psychology can provide a twofold benefit. And this is especially the case for DSPs. So first, it promotes a strength-based lens through which to view the person who's receiving support. And in working in a rather deficit-focused system of care, that can be quite radical. That was the radical strength-based focus that I referred to in my intro. And then secondly, it builds self-awareness and a positive use of self for the DSP to help them see themselves and use themselves in their work. And we think that healthy and happy DSPs might actually provide an enhanced quality of support by moving beyond compliance to that of supporting people with IDD and mental health needs to thrive in their communities. And the starting point, the foundation of that is possessing that mental health literacy. So as you can see, really focusing on our guiding principles, and this is the lens, if you will. We're crafting our lens in the first session. And then in the second session, focusing more on what IDD is and what are vulnerabilities that are associated with IDD to be aware of. And then we start to fold in the mental health aspects of IDD. Identifying signs and symptoms related to mental health, that's building literacy. An overview of the most common mental health diagnoses, right? So people can know what to look out for and also just know what's most prevalent. It's often not something exotic like a psychotic disorder. It may often be anxiety, depression, or a trauma or stressor-related disorder. And we have a whole session really devoted to trauma because it is so prevalent in this population. And then moving into what we can do, positive identity development, defining what trauma-informed care in action means, how to promote resiliency, how to promote wellness, emotional recognition and regulation. And that's the DSP teaching the people that they support to be able to recognize and regulate emotions, relaxation and stress reduction, and using their creativity. So I'm a visual person. My guess is that a lot of you are too. This is an example of how the course goes beyond simply identifying mental health symptoms and offers a framework and tools for promoting mental well-being. So we use PERMA, which is the model of well-being that has been adapted by positive psychology. As you can see, P stands for positive emotions, E stands for engagement, R is relationships, M is for meaning, and A is accomplishment. And those 5 ingredients put together are sort of the recipe for well-being. So we define what each of those building blocks are. And then as you can see, and I know that the text is small, so I'll describe it verbally, we have this PERMA assessment. And we prompt the DSPs to think about, based on what you know now, your support of this person, your observation, perhaps prior knowledge about the person, how does this person experience PERMA? And where are there gaps or areas of need where you or others might be able to enhance their feeling of PERMA? So it's a worksheet, but it also kind of becomes a roadmap, right? Because when you identify gaps, you can then identify plans to fill those gaps and to resolve them. It may sound as though I am oversimplifying. This practice is both cognitive in nature, so helping the DSP to begin to think with a wellness-focused lens, and just beginning to conceptualize what well-being for this person looks like. And it's slow and steady, right? When I have used this assessment in my own practice, I have seen wonderful results. People kind of take it and run with it, right? Because rather than addressing it from a more behavioral perspective, you're really addressing it at the root of what the person's character strengths are, and I referred to mine at the beginning, and how they can use those in achieving or seeking PERMA. Okay, and continuing with my visual and experiential teaching style, I'm going to share a clip of a recent DSP course session. And I chose this clip because it demonstrates several key characteristics of the course and sort of what teaching mental health literacy looks like in action. So you'll see number 1, co-facilitation between NCSS team members with and without lived experience. You'll see teaching to a tool that can be applied in a DSP's daily practice. And a tool that itself demonstrates mental health literacy, as well as sort of the narrative that's offered by the facilitators that helps to decrease stigma that might be experienced by people with IDD in a typical daily setting. This video is about 4 minutes long. I'm going to play it, mute myself, and then we will come back together. And if there's any issues, please just speak up and let me know.
I've worked in several places where everybody's encouraged, everybody's allowed to take a break, and everybody's encouraged to ask for one. But some people have scheduled sensory breaks, and some people will encourage others to take a break in a way that feels a little bit like you're being punished or kicked out of the room. And you always want folks to understand that a break is a positive thing. It's a minute to reset and catch your breath, and it's something that everybody needs sometimes, regardless of their ability. So you want to be neutral to positive when you're presenting it.
Yeah, and try avoid using words like timeout or things
or
like
you
that.
need a break.
And using it with that negative connotation and negative tone, because yes, like you said, it can really affect the person on how it's presented.
Some people, like I've had people be really reluctant to do it even when they really needed it, because they perceived it as, oh, that means I'm in trouble, or that means I'm doing something bad.
Yeah, exactly. And this is just another example. This is another example of how you can give a person a little bit more autonomy and control, is have these cut out, laminated, and they can bring this to you if they need a break. That way they don't even have to use words. This is just something that they can use as a tool to feel more empowered. And I would also like to note that if a person recognizes this about themselves, and they come to you and they say they need a break, praise this. Raise it, even if the delivery was not great, if they interrupted you with something, you can still praise them for it, because the more you praise things like this, you're going to get a better response. So I usually say something like, thank you for letting me know. I'm really proud of you for recognizing that you needed a break. That has always been really helpful. So always bring attention to it. So now I'm going to pass this back to Micah to talk a little bit about social stories and role playing.
So these get talked about a lot. These are known helpful strategies for folks with developmental disabilities and intellectual disabilities. And they help us to better understand and practice social expectations, routines, and skills. And this is because our brains get so much information that we have trouble connecting it sometimes. And so we often experience social situations or situations just generally where lots of different things are happening as being kind of decontextualized. So social stories help us to string one event to another, to connect all the things together and put them in context. And they help us know what to expect in particular situations. Lots of us are systems thinkers or category thinkers, and they help our brains to make new categories to say, oh, this is a kind of experience I can have. This is a kind of a thing I can expect. And they can be really easily modified or personalized for things that are going on in a person's life, or made to fit a person's cognitive and communication abilities. So here's an example of understanding that sometimes people are busy, and that's the reason that they might not be hearing you. It's not that they're ignoring you or that they don't like you, and it doesn't mean that you're bad, which can be a really easy way to read being ignored when you've grown up with disabilities. And it both helps us to understand what's really going on, but then it also offers us some ways to deal with it at the end. It says, when people are busy, I can say, I will talk to you when you are done, and I'll get a chance to talk to them later. We're still friends, and we can talk when they're not busy. So it provides both an understanding of the situation as well as some concrete solutions for us to act on.
So before I move on, I'm wondering if anyone has any.
I've worked in several.
I'm wondering if anyone has any immediate reflections on that clip or questions that you have, and you can use chat or you can use raise hand. Kayla.
Hi everybody, I'm Kayla Robertson. I'm in St. George, Utah with our RCI. My pronouns are she, her, and I have blue eyes and brown hair that's braided back in a single braid with a purple shirt on. I just love this clip, especially when it started out with the talk about interruptions, because I personally work with a lot of kids and youth with disabilities, and interrupting and knowing who can have a turn is really, really difficult. As well as I've worked as a direct support professional for a few years before I started doing this work, and working with the adults is often something you have to reiterate, and positive reinforcement is one of the most it's the most effective way to really help them build these good behaviors, and to really understand that their feelings and their desire to participate is valid and important, while also maintaining the boundaries and helping them to understand where those are. So I love that they mentioned that in that clip.
Thanks so much, Kayla. You did a really nice job of sort of highlighting or tuning really into the intent of that demonstration of that tool. I started my career in direct support in a school setting. And we did something, little did I know that there were such a thing as chill passes, but we did something very similar, right? Giving people an opportunity to non-verbally express their needs and to take some space in whatever form they need to. You know, I think that they use the words autonomy and empowering, right? And those types of words tend to build wellness, right? When people feel that they are in control of their day and that they can make their own choices, that's going to build a sense of wellness. I don't want to spend too long because I have a couple more slides, but if there are any other reflections, we are
places where
going to have, I'm going to have another check-in right after this slide. So what is a training course if not for outcomes? And I think that this slide demonstrates two things. Number one, that the training course does have a positive impact on learners, and we'll go through the scores in just a moment. But two, that the objectives of this course embody what mental health literacy means, right? So I could have spent a lot of time today just to sort of talking about the principles of mental health literacy and the implications of low literacy, which we talked about a little bit. But I thought that it was more valuable of all of our time to focus on what we can do to build mental health literacy, what is being done, and there is so much more work to be done around this space. So as you can see, there are, I believe, 5 objectives. And what we asked participants to do during their post survey was to rate themselves retrospectively. So they had this table that had a side-by-side of each of these objectives. And then we asked them to think, before this training course, how would you rate your abilities, right? On a scale of 1 to 5. And these percentages here reflect people who rated in either a 4 or a 5, which is good or great. And then we asked them to think about themselves in the present moment as they're taking the post survey. Now, how would you rate your ability based on each of these objectives? So you can see that people from pre to post demonstrate an understanding of IDD and the presentation of co-occurring mental health conditions. Before the training, 54% rated their ability as very high or high. So good or great. And then after the training, 97% said, I got this. Demonstrate a biopsychosocial understanding of a person's strengths and vulnerabilities. 41% felt good about that pre-training, 97% after. Apply a strength-based therapeutic practice, intervention, and skills to support people. 46% pre, 95% after. Effectively facilitate therapeutic activities. 51% pre, 92% after. And engage in positive and wellness-focused interactions with people with IDD, families, and colleagues. 69% felt that they were high or very high before, and then 97% after. So all of the post-training scores falling well within the 90th percentile after training indicates to us that there was an increase both in competence, but also in confidence and feeling better about the supports that they're providing to people on a daily basis. Okay, so here's where I'm coming back to you all. I'd like to hear what you think. What stands out to you about the pre and post scores? And what implications might training like this have for the DSP workforce? And you can use chat or raise hand. Hi, Kayla.
Hi, sorry, I feel like I'm speaking a lot, but just to clarify, the question is just kind of going off these two questions on the screen, correct? I think one of the things that I was really impressed about the just the data is that the response after doing the assessment and looking at the way it is was significantly higher, and I think that really does show that the importance of learning the things for ourselves. When we are given the chance to be able to have that opportunity to be autonomic, and we're able to make those learn those skills, that's the word I'm looking for, we really do have higher scoring with the surveys and things like that, I think, and really I think it sticks better in terms of learning those behaviors. So
Thanks, Kayla. I like the stickiness comment because that's really what we're looking for as trainers and educators, right? Is to make learning dynamic and highly applicable, right? If we're not talking to DSPs, if we're not speaking their language and tuning into their daily experiences, then that learning isn't going to resonate, right? And so as you saw from that clip, there is a lot of talking and teaching around the tools and materials that they're given access to through the course. That's going to build literacy. And Rachel, thanks for your comment about mentioning both competence and confidence. It is important for DSPs to have the knowledge and feel confident to use it, right? And those are two different skills too, right? To sort of possess an understanding of theory, and then to make that leap to applying it, and not just applying it, but generalizing their understanding, right? They might understand what mental health literacy is, but how does it show up in their daily jobs? As a social worker, I'm very comfortable with silence, and I want to just give people space to share any other comments or questions. If it's not about the 2 bullets on the screen, that's okay. Now's your time. Ashley.
I want to approach it from kind of a systems level. I think in terms of implications for the DSPD workforce, our systems haven't done a really great job in terms of support and education and training. And we know that the need is there based on those results, right? So we collectively need to work together to improve those systems. And a part of that is really, unfortunately, is our responsibility to advocate for ourselves as a workforce and say, hey, we need this. And so approaching management, approaching supervisors, and asking for these kind of trainings to come in, or taking time to attend trainings if they're externally outside of the agency. But I think, largely as a group, we need to hold systems accountable and say, this is a need and you need to help support us.
Thanks, Ashley. I think it's really promising that in my experience, especially over the last several months, we've had conversations with a lot of new partners, right, who have expressed an interest and commitment to providing enhanced training for their DSPs. I mentioned I did a little sidebar soapbox at the beginning around sort of the DSP workforce crisis, and there are many contributors to that. And it would be beyond the scope of this presentation to speculate on that. But one tiny sliver of the solution does lie in training. Relias just released a report, and I've provided the link on the next slide with some resources, and they highlight the need for more training. Good training can also help, as we mentioned, DSPs really see themselves in this work and see themselves as a valuable member of the human services delivery system. But Ashley, you're absolutely right that it's one thing for them to see value in the role that they do, but it's most important that the entities that they're working for also see value, not only in the work that they do, but the skills that they bring to their everyday job. And with so many people with IDD experiencing a mental health need at some point or another in their lifetime, and with the high rates of trauma that we see within this population, mental health literacy to me seems like really low-hanging fruit, right? Like something that can just sort of be a foundational element of training. I'd love to see it get there someday. That's my vision. I'm reading the chat here. Oh, Dakota wishes that this had been around when you were a DSP worker, and wonder about the push and availability for places like group homes using it to train staff. This is information, and after I'm done talking, I will put the link into the chat. This is the course information is public. You can find the rundown of the sessions. No recordings of the sessions are publicly available, but you can point them to the website, and perhaps that's an action item that you take as a result of this presentation today. And Kayla, a few parents, we've had many parents go through the DSP course training, and many parents who serve in dual roles, who are both working within the system and parenting a child or an adult loved one. Okay, so I talked about resources, and I'm also mindful of my time. The National Center for START Services, so there's a link to this DSP course here. I believe that Rachel sent this out as a separate handout, so you should have this readily available to you. Anything that's marked with an asterisk I felt was notable, but not mental health specific training, but just important in the grand scheme of a DSP. So then we also have training from the National Association for the Dually Diagnosed. The National Alliance for Direct Support Professionals is a wonderful resource, and they have a list of competencies for DSPs, also in the interest of professionalizing DSPs as a profession. The College of Direct Support, another fantastic training resource, but not mental health specific. Mental Health First Aid Australia. They're doing something good down under. It was truly the only resource that I could find around mental health first aid that had been adapted for people with IDD. And I loved this handout. So you all can take a look at it. I thought it had some really tangible, practical pieces that you could pull out of there. ANCOR, the American Network of Community Options and Resources. I mentioned that they just released their 2023 DSP survey report, and they did that in conjunction with Relias. So take a look at that. Very easy to read. And then the Council on Quality in Leadership, also known as CQL. Also offers trainings focused to DSPs, but not mental health specific. So in the last 2 minutes of our time together, what's next? What's one action that you'll take as a result of what you've learned today? And while you're sharing any reflections in chat, I will just scroll through the remainder of my slides. Here are references. If you are a nerd like me, you can put these into Google Scholar. Most of them are open access. And please be in touch. I love getting emails. I respond quickly, and I'd love to hear from you with any questions that you might have. And as Rachel said, don't leave yet. After my presentation, Matt's going to do a case presentation. All right, well, if you are inspired to share in chat anything that you plan to do as a result of today's training, I welcome you to do that. And if not, thank you for having me. It was a pleasure to talk to you all.
Thank you so much, Beth. That was very meaningful, and I'm so glad that you were able to be here. Next up is the case presentation portion of this ECHO session. Today, Matt Wappett will be providing that for us. He is the executive director here at the Institute for Disability Research, Policy, and Practice. I will let you go ahead and take it away, Matt. As a quick note, what we'll do is Matt will provide an overview for the case. We'll ask any clarifying questions, and then we will split up into breakout groups. Each group will have one question to discuss. Sarah will be helping direct 2 groups, and she will let you know what question your group will be discussing. Each group will have at least one hub team member to help facilitate. If you end up with multiple team members in your group, make sure you discuss and figure out who's going to facilitate and who's going to take notes, because at the end, we'll come back and discuss the case as a group.
Okay. Do you want me to share my screen?
Yep, that'd be awesome.
Okay. All right, got it. There we go. Oh, no, that's not it. Let's see. There we go. Hopefully everyone can see that. Well, as mentioned, I'm going to walk through a case presentation that's going to provide a context for our discussion. As Beth has pointed out, there's a lot of things that direct support professionals can do to help support families and individuals with intellectual and developmental disabilities. And we're going to see how creative and how closely you were listening. So what I'm going to do is present a case. This is a real case that occurred here in the state of Utah within the past few years. And it's a great example, I think, of just the complexity and the importance of paying attention to the mental health needs of an individual with intellectual and developmental disabilities. I will tell you, before I get into this, I'm not going to tell you right up front how the case was resolved. I can do that at the end, but so that'll give you some incentive to stick around to figure out what exactly was going on here. So with that said, let me jump in. So a little bit of background on the case. It's a 43-year-old white female with intellectual disabilities and significant communication issues who lives in rural Utah. So this individual lived at home with her parents. Her parents were her primary caregivers. They were aging, however, they were in their 70s. The individual received home and community-based services during the day from a local disability service provider. And prior to this particular event, no prior behavioral issues or diagnosed mental health issues had been noted within the individual's case file. The individual's on minimal medications. She did have an acid reflux medication, which tends to come just with aging, and then blood pressure and cholesterol lowering medication, but essentially primarily just medications due to the regular aging process in an individual who was just slightly overweight. And then she would use NSAIDs. Those are non-steroidal anti-inflammatory drugs. So that would be like ibuprofen or Tylenol as needed. So anyway, a relatively typical case. Now, the primary area of concern, this individual started to experience stomach pain, aggressive outbursts, and frequent emotional breakdowns following a car accident with her parents. These incidents also included frequent waking during the night and occasional vomiting. So there was some concern that maybe something occurred during that car accident. So the parents took this individual to primary care physicians. Those primary care physicians were unable to identify the cause of the pain. They actually ended up traveling to Salt Lake to the University of Utah Medical Center for some additional consultation. But it was very difficult because of the patient's communication issues to figure out exactly what was going on. So her outbursts, when she would have them, the insomnia, the breakdowns all seemed to correspond with an attendant rise in her pulse rate, her blood pressure, the acid reflux and upset stomach would get worse when she would have these episodes. So because of her communication deficits, the doctors had a really hard time figuring out what was going on. They ordered MRI, CT scans, x-rays. They eventually actually decided to conduct an exploratory abdominal surgery to see if there were any undetected issues from the accident, but none of these efforts identified any underlying physiological problems. But the outbursts continued, the behaviors became more problematic for her aging parents to manage, and they placed day program staff at risk. They tended to become more severe. These outbursts became more severe before travel, making it increasingly difficult for the parents to take the individual to her day program, or for day program staff to transport the individual to her job site and to participate in community activities. So that's kind of a broad overview of the case. What we would like you to consider are, as you go into your breakout groups, are some of the goals. Some of the goals we'd like you to think about and that the parents wanted addressed was how to address the chronic stomach pain, how to address these outbursts, breakdowns, and the aggressive behaviors that started to manifest after the car accident, and then helping to identify a medication or a behavioral solution that would help protect the parents, the staff, and the individual. Now, the barriers to keep in mind are that there are some significant communication deficits. There are no evident underlying injuries that could be causing the stomach pain. Pain medication that's over the counter and prescribed has no clear impact on her stomach pain. And the other consideration is that parents and providers live in a rural area where access to medical and behavioral specialists is limited. So with that said, some of the questions I think that we're going to consider here in our discussions, and these are things, again, there's no right or wrong answer to these. This is a case for us to do some brainstorming and problem solving. But number one, are there any conditions, specifically trauma or mental health related, that might present with the symptoms displayed by the patient? Number two is, how can direct support professionals who work with the individual help the family and individual address the identified problems? And then how can DSPs involved in this case help document and track specific behavioral patterns that might help the parents and medical professionals more accurately identify triggers? And then three, what would you suggest as next steps for this family to try to address the problems identified? So with that said, I guess I can open it up briefly. Are there any questions that anyone has before we go into our breakout groups? Kayla, I see your hand up.
Yeah, I just had a quick question. In terms of the doctor's appointments and things that the parents took the individual to, were those just like the CT scan and the MRI? Were those the only two that they really did, or did they do other testing?
They did other testing. So they did, I don't have a whole list of everything that was done, but they did look at soft organ, soft tissue injuries, but also bone. So they did x-rays, blood tests. Yeah, kind of a whole range of workups there.
Gotcha.
Yep. Any other questions about the case? Okay, well, I guess with that said, now that you kind of know what you're supposed to think about, Rachel, are we ready to go into breakout groups?
Yep, I think so. Sarah's going to help us split up into those breakout groups. You should have gotten a message from Sarah if you are a facilitator with a question that your group will be discussing. James, you will have question 4. We can go ahead and get split up. Welcome back. We'll give it a second so everybody can come back to this main room. And then we'll go over the questions together, take some notes so that I can send out these recommendations after the session. All right, it looks like we have everybody back from our breakout groups. Thank you all for participating. We have a few minutes left. What we're going to do at this time, we'll go by one question at a time. If someone from your group would be willing to share what you guys discussed, I will compile all these notes and recommendations and we'll post them on the Canvas page and send them out in an email after. That being said, my group had question 1. We talked about conditions that might present with the symptoms displayed by the patient. We discussed anxiety. Anxiety is often associated with physical symptoms like stomach pain, stomach upset, as well as PTSD that can have some physical manifestations as well. We did kind of start talking about the other questions because we felt like there was some relations between the questions that are important to note. So one thing that we did discuss was also documenting everything thoroughly will help be able to see if there are conditions that might be related, thinking about what happens before the anxiety or stomach pain is experienced, what happens after, some of those contextual factors. And we also thought maybe the communication barrier might add to the anxiety if that's being experienced. It might be a compounding factor that escalates that for them. So just really thorough documentation from the DSPs, and then thinking about anxiety, PTSD, those conditions that often have or are often accompanied by a physical discomfort, especially in the stomach. Whose group had question 2?
That was us, I believe.
Okay.
And ours was, how can direct support professionals who work with the individual help the family and individual address the identified problems? We had a good discussion. One of the things that came up was exactly what Beth talked about in her presentation, teaching the individual to take a break and teaching the individual to recognize triggers and when they're starting to get upset, and then working with them to develop some way to communicate that they are starting to feel these things and that they need to take a break. We also talked about a little bit more on communication, how it's, again, as Beth brought up, it's important to develop a system and then to have that system be consistent across, the day program setting, but also at home. And so the DSP could figure out what works in the program setting and then work with the parents to help them identify, ways they can implement that same system in the home so that there is that consistency, which is important. We also talked about the importance of documentation and relationship building. So again, building that relationship with the individual so the individual is comfortable communicating with the direct support professional, and then documenting changes in behavior. Again, a lot of mental health issues are reported on self-report. And if an individual is unable to self-report, a lot of times the only thing that we have to go by is behavioral changes. And so a direct support professional who spends a large portion of their day with the individual can document those changes and help identify triggers and potential issues that come up. We also talked a bit about the need to evaluate for trauma, right? It's clear this happened after a car accident, and, recommending to the family to get some sort of an assessment for trauma or a mental health issue, panic disorder, would be really important. But again, the important thing was that the DSPs be seen as a valuable member of the team because they spend so much time with the individual. It's important that they be consulted and looked at as a professional and somebody who can contribute to, I think, making decisions about the treatment of the individual in this particular case. So anyway, I think that's about it. Anything I'm forgetting? Anyone else in our group want to fill that out?
Those are great notes. Thanks,
Okay.
Matt.
Yep.
And question 3.
believe that's us. We had talked about some of the similar things as far as like tracking goes and trauma. So like tracking the antecedent, the duration, time, intensity, the client's experience, individuals, also like meals and sleep, because maybe she's not sleeping well, you know, that sort of thing. And then we also talked about using social stories and how that could be really helpful of like preparing her to travel, right? And like we're going to get in the car and then we're going to go here, and like car accidents don't always happen, we're most likely going, you know, that sort of thing, because maybe there's still some difficulties with like the trauma of being in a car accident. Someone also mentioned like maybe getting tested for ulcers, and that could be part of the problem. I don't know what her stomach surgery thing entailed, but that could be it. We also talked about like utilizing calming strategies, like could she be experiencing some panic attacks or, you know, something like that, and building up tolerance for sitting in the car. So like we're just going to sit in the car for 5 minutes and that's it, and then we're going to like sit in the car for 10 minutes, and then we're actually going to travel for 5 minutes, or, you know, something like that. And can we pair it with things that she enjoys or finds rewarding? And then also like the use of music as a possible thing for like communication or sleep or emotions, that sort of thing. So yeah, I think that's all.
Awesome. Thanks, Dakota. And we talked about ulcers too a little bit in our group, looking at potential underlying conditions that might fly under the radar sometimes that can be cause a flare up from anxiety or panic disorder. I like that was brought up as well. And lastly, question 4, I believe that was James's group.
Yes, so I'm going to talk about that. So we also talked about data collection and documentation, and having the family gather some data, and, you know, maybe compare that to what direct support professionals are seeing, kind of compare those antecedents before the behavior to see if there's any similarities. We also talked about having her see a therapist and or a psychiatrist. And then along with that, since communication could be a barrier, what are other ways that she can use to communicate rather than verbally? So try to find some ways for her to communicate. And then we also talked about medications, or can they try some different medications with her, see if any of those help. And along with that, that could also help maybe some of her physical symptoms, as you know, stomach pain can be a symptom of anxiety. So maybe helping some of those physical symptoms kind of subside might help her be able to focus on some of the other, you know, maybe mental health issues that she is experiencing. So those are some of the things we talked about.
Awesome. Thank you all so much. I've written down some notes from each of our groups. I'll make sure to compile these, put them together. We'll post them on the Canvas page. We are now past our time of 12:30. I appreciate you all who stayed the full time. I know this is a big chunk of time to dedicate to this, but we really appreciate it. I did also want to just note, the Utah MHIDD Training Initiative is facilitating DSPs participating in that START training that Beth talked about today. We're working together with them. So if you have DSPs that you're aware of who may be interested in that, our next cohort is this fall. We'd be happy to help facilitate that. We help to offset the cost. We are also working on providing an in-person training for DSP locations, so ICFs, day settings. If you are interested in that as well, let me know. We'll keep you updated as that becomes available. I will be one of the individuals conducting that training. We'll send out a follow-up email. The June session link is in the chat. Please fill that out if you'd like a certificate of attendance or the CEU certificate. And I think we are all wrapped up. Thank you again for coming, and let me know if you have questions. Reach out via email. We're happy to touch base and work together.